Very good morning, ladies and gentlemen. We've negotiated our way through the dust in the parking lots and everything, so we've come a long way here coming to this hall. So let's make the best of our time. So I'll be discussing this very challenging topic, which is a challenge, challenge for our treatment, how to go about it. And basically these veno-lymphatic malformations there's a spectrum. They can be either purely venous or purely lymphatic, but in actual clinical setups, you do not see most of the pure venous or the pure lymphatic ones, but usually they are in between, the veno-lymphatic combination. But the pure venous ones, these are some of the characteristics of those slowly growing, well circumscribed. And the lymphatic malformations, again, are a congenital slow flow vascular abnormality resulting from abnormal development of the lymphatic system. And these are the incidence and the sex ratio. And usually they are diagnosed at birth, and most of them affect the head and neck region. And within that, our purview is for the orbital lesions and the periocular lesions, where we see them in our specialty. And they can cause occasional complications in between, like sudden, intralesional bleeds, infection, swelling, and causing sudden blepharoptosis and proptosis, and leading to some urgent situations where you need to manage them. And so they are basically classified into macro and mixed variety, depending on the cyst size in between there. The macro ones have obviously very large cystic cavities, and the micro ones on imaging are having a small cyst which are barely visualized on imaging, whereas the mixed variety has a part of both. So this is a MRI image of a macrocystic one, where you can see some fluid levels. And I put the other extreme, which is the microcystic variety, where it's just a large diffuse mass where you cannot really visualize the cyst there. So these are very small cysts, and it's almost an organized solid mass there. So presently, what are the treatment options that we have? Like for many years, we have been doing debulking surgery for these lesions with variable success, because as you know, the main problem is that they're very, diffuse, and they are not a circumscribed lesion. So they are involving the entire orbit and even engulfing the optic nerve. So at best, you can debulk some part of the lesion without compromising the lesion. And steroids we have been using for acute exacerbations, and when there is a bleed or there is a sudden increase in the lesion due to some episode which leads to increase in the lymphatic glands and the tissues. And the various sclerosing agents have been used over time historically, which are listed here. I think you're all familiar with most of them. And now picibellin is one of the supposedly the best agents, but the problem is that it's expensive and it's not available. You have to import it. Whereas bleomycin and its derivative vingyangmycin we found them equally effective. They are cheap, they are easily available here, and they are very good for our patients. So in an Indian scenario, we found bleomycin to be a good substitute for the other agents. And recently, of course, sildenafil and then cyanoacrylate glue for the superficial lesions and fibrin glue for the deeper lesions have also been tried. So why did we choose bleomycin? Because as I told you earlier, these lesions pose a therapeutic challenge, and the surgical management is fraught with danger, and it may not be so effective, and other sclerosing agents may have some serious complications, whereas the most common complication of bleomycin in the head and neck region is pulmonary fibrosis, but it occurs at doses which are even maybe 20 times more than the ones that we require for the orbital lesions. So pulmonary fibrosis is not an issue as far as our lesions are concerned. And then it's a very non-invasive procedure, and I'll just show you the outcomes which in our series of patients, right? So we'll just go on to the mechanism of action. Various things have been described, but basically it causes inflammatory reaction and fibrosis, or thrombus formation, or oxidative damage. As you know, bleomycin is an anti-cancer agent, so one of the mechanisms is through that, and the other ones are due to the inflammatory reactions that it causes. Of course, apoptosis. Apoptosis is also an important mechanism, and the list goes on and on. You can, just for academic purposes. So now people have described various doses, various permutation combinations. Some people do it according to the per kg body weight, but we found that the safest is to give 1 international unit per ml of saline mixed with lignocaine, and that is a safe dose, and it is quite effective. And we give the injection either with a 26 gauge needle or a 23 gauge needle, depending on how much deep you want to go. And in the macrocystic variety, after we aspirate the contents, without withdrawing the needle, we can inject a volume equal to what was aspirated. And we have also tried this in cavernous hemangiomas, low flow venous malformations, and in the microcystic and mixed varieties. You can inject a volume equal to the largest pocket of the lesion, or the one that is measured, which is with MRI or USG, subject to a maximum of 5 ml, because we've seen that if you inject more than 5 ml, then it can cause pressure symptoms inside the orbit, and it may be causing its own problems with compressive neuropathy. So we did send the samples for cytopathological examination, but usually it came out as a blood only. And then you can give serial injections at an interval of 4 to 6 weeks, up to a maximum of, say, 3 to 5 injections, and it does lead to a progressive reduction in the size of the lesion, depending on the response that you got with the first or the second injection. So this is a short video we are doing it in a real-time ultrasound B-scan monitoring, after identifying the pocket on that and corroborating it, of course, with the MRI findings. We go in that quadrant, and then with a larger syringe which can cause more negative pressure, we go and try to aspirate the lesion. You can move the syringe a little forward and backwards to find the exact largest point where you can aspirate. And then without withdrawing the needle, you can inject bleomycin 1 international unit per ml through the same needle into that exactly the same point from where you aspirated the contents. And then after that, pressure for about a couple of minutes, and then followed by a short course of systemic steroids, and local NSAIDs is helpful. So usually pre-op, we do a UBM, a USG, and preferably an MRI for the patients. Sometimes CT may be more useful for volumetry, but that is, MRI is also equally good, and one should prefer doing an MRI. And we graded the response from an excellent to a poor response according to this classification. And now I'll just show you the cases where it was done. This was a case which had a massive kind of a swelling and a proptosis, and this is the post-injection finding. These are the MRI pictures where you can see the very clear fluid levels in this. And now after the injection, you can see how much the lesion has regressed. Another case which had a component in the orbit as well as an anterior component in the lid. And you can see after the these are not only after one injection, some are, multiple injections also. So we are not going into that right now, but usually we give about the maximum of 5 injections. So you can see both the components have significantly regressed. And these are the imaging findings of this case showing both the orbital and the anterior component. And below the 3 pictures, you can see the post-injection imaging findings. Okay, so I think we'll just take last few slides. Can you just take off this? Yeah. Okay. Right. So another patient showing both orbital and lid findings, the post-injection findings. The MRI, you can see a very dramatic reduction in the lesion on MRI. Another case, she had an orbital as well as a component on the forehead. So this is what we did for the orbital component, and then she had serial injections for the forehead component, which also reduced almost to normal. So the point is that not only can you do the orbital one, you can do the eyelid and the, lesional component also. But the only precaution that you should take is that you should give a deep intralesional injection, because if you give it very superficially, sometimes it can cause some excoriation of the skin. So go deep into the lesion. Again, another case, this is the same case which I showed you the picture. You can see it almost regressed to normal. Another case from Northeast, he had a significant proptosis and an orbital component. And you can see his pictures here that it's significantly reduced. And this was our first case actually, which we did. She had a very large orbital lesion, and now she's absolutely symptom-free. And absolutely all these patients had no disturbance in vision. All the patients had perfect vision even after the injections. This is that case imaging findings which I just showed you, case 6. And so I think we are running short of time, so we'll just run through these last 3-4 patients. Another patient showing that you can see that such a large lesion and regressing to just few minimal pockets later on, and a significant reduction in proptosis. This patient had a cyst in the lower eyelid, in the preseptal cyst in the lower eyelid. So it's a little different from the previous cases. And you can see there are fluid levels there, and which have now totally resolved. So there are few complications. You can have conjunctival chemosis, which is transient. Like I told you, if you give an injection superficially, or if it extravasates into the superficial compartment, it can cause this thing, little skin discoloration, and subconjunctival hemorrhage, which are all manageable. So just to conclude, it's a very safe and effective agent for these lesions, and it can be considered as a first-line management. Rather, it should be considered. And repeat injections can be given, as I already discussed. And it's a very minimally invasive procedure which avoids the need of major surgical interventions, which could be ineffective and could lead to sight-threatening complications. Thank you for your attention.